Hello everyone. Today I will be discussing to you systemic lupus erythematosus. Systemic lupus erythematosus or SLE is an inflammatory autoimmune disorder that affects nearly every organ in the body. It occurs 6 to 10 times more frequently in women than in men and occurs more in African American populations. The overall incidence of SLE is estimated to be 1.8 to 7.6 per 100,000 persons. The factors that may play a role in predisposition of SLE include genetics, hormones, ultraviolet rays, exposure to viruses, stress or diet, certain medications, use of oral contraceptives, earlier onset of menarche, and hormone replacement therapy. The pathophysiology of SLE starts with the body's immune system inaccurately recognize one or more components of the cell's nucleus as foreign, seeing it as an antigen. The immune system starts to develop antibodies to the nuclear antigen. In particular, these cells begin to overproduce antibodies with the help of multiple cytokines. The antibodies and antigens form antigen-antibody complexes and have the propensity to get trapped in the capillaries of visceral structures. The antibodies also act to destroy host cells. Since SLE affects almost every system in our body, it presents with a multitude of generalized symptoms. For the skin, the patient may manifest butterfly-shaped rash of the face and discoid lesions. For musculoskeletal, clinical manifestations may include arthritis, tendon deformity, and tendon rupture. Cardio-related symptoms are pericarditis, myocarditis, endocarditis, and coronary artery disease. For pulmonary-related symptoms, it includes pleuritis, pleural effusion, lupus pneumonitis, pulmonary hemorrhage, and pulmonary embolism. Gastrointestinal symptoms include oral ulcers, acute and subacute abdominal pain, pancreatitis, spontaneous bacterial peritonitis, and bowel infarction. For the renal, the patient may experience nephritis and renal thrombosis. For the CNS, signs and symptoms are neuropsychiatric disorder, transient ischemic attacks, stroke, seizures, migraine, myelopathy, Guillain-Barré syndrome, career and under movement disorders, and poor concentration. Hematologic symptoms are hemolytic anemia, leukopenia, and thrombocytopenia. For vascular symptoms, the patient may experience hypertension and Brennan's phenomenon. For constitutional manifestations, the patient may also experience fever, weight loss, and fatigue. SLE is diagnosed by a healthcare provider using symptom assessments, physical examination, x-rays, and lab tests. SLE may be difficult to diagnose because its early signs and symptoms are not specific and can look like signs and symptoms of other diseases. So CBC can be ruled out to test for leukopenia, anemia, or thrombocytopenia. ANA or anti-nuclear antibody is also used, and it is the primary test to help evaluate a person for autoimmune disorders. And more than 90% of patients with SLE are positive for this test. Next is the Anti-Dopa stranded DNA test, and it is used to help diagnose lupus. It is usually done if the patient has a positive result on a test for anti-nuclear antibody. Next is the complement levels. It is a blood test that measures the activity of certain proteins in the liquid portion of our blood, and it is generally decreased when SLE is active on patient. Next is the urinalysis, which is used to test for hematuria, proteinuria, and active sediments. The patient may be also required for a 24-hour urine to test for protein and creatinine clearance. Chest X-ray and X-ray of hands and wrists may also be ruled out. For patients with SLE, non-destructive arthritis may be evident. Other diagnostic procedures include CT scan and MRI. For pharmacologic management, the patient may be prescribed with NSAIDs to reduce pain and inflammation, antimalarials to decrease disease activity, calcium channel blockers and ARBs for Raynaud's phenomenon, immunosuppressives to suppress immune process and to act as steroid-sparing agents, antihypertensives and diuretics to treat hypertension and fluid overload, and corticosteroids to reduce inflammatory process. Generally, the nursing interventions of SLE aim to reduce pain, increase control over the disease process, maintain skin and mucous membrane integrity, reduce fatigue, and preserve urinary elimination. In reducing pain, administer and teach self-administration of medications, encourage application of hot and cold, and teach relaxation techniques. In increasing control over disease process, avoid factors that may exacerbate disease, teach self-administration of pharmacologic agents, and encourage good nutrition. In maintaining skin and mucous membrane integrity, apply topical corticosteroids to skin lesions and encourage good oral hygiene. In reducing fatigue, advise patients that fatigue level will fluctuate with disease activity. Encourage patients to modify schedule to include several rest periods. And teach relaxation techniques such as deep breathing, progressive muscle relaxation, and imagery to reduce emotional stress. In preserving urinary elimination, monitor urinary status and check patients' test results. Some of the nursing diagnoses for SLE include chronic pain related to inflammation of joints and juxtaarticular structures, powerlessness related to unpredictable course of disease, risk for impaired skin and oral mucous membrane integrity related to skin and oral lesions, fatigue related to chronic inflammatory process, and impaired urinary elimination related to renal involvement. The prognosis. The seriousness of SLE ranges from mild to life-threatening, although most people are able to live a normal life with treatment. The survival rate in persons with isolated skin and musculoskeletal involvement is higher than those with renal and CNS problems. That's all for today. Thank you for listening.